Hello, everyone. Today, I am super delighted to be speaking with Jacey Cooper. She is the California State Medicaid Director, and I have been looking forward to this conversation for a long time. As some of my listeners may know, um, Medicaid is changing around the country as a result of new federal imperatives. And in California, it's some of the changes are leading to opportunities around housing and accessibility in housing that were not previously in any way connected with Medicaid or Medi-Cal in California. And that's what I wanted to talk to JC about. Thank you for being here.
Thank you for having me.
So, JC, can you describe at the broad level how Medicaid in California, Medi-Cal, is changing with regard to a more broader range of potential services being offered to consumers of it?
Yeah. So, we've been talking across the nation for a while and in California, and we're really looking across the benefits and services that we provide and clearly saw a gap in regards to the various services and supports that we felt people needed to kind of remove the barrier that's not allowing them to receive actual healthcare services. Things like housing, medically supportive foods, home modifications. And really, we had been piloting this in California for a while as well, and really wanted to think about how do we bring those into the broad Medicaid program? How do we take that out of just the hard to reach home and community based waivers that can exist in Medicaid or smaller niche programs and think about leveling that up so that more Medicaid beneficiaries can have access to certain services and supports? So it was really around thinking about what are the things that are creating barriers of care for someone to receive healthcare services. There's always an intersection, I would say, though, with what we're providing with help, which I think is important for people to understand. But it's really those kind of more social or health related social needs, is what we're calling them, that really we felt were going to be important for people to have access to. And so we created a list of them. We did a whole process to develop what people would need to be able to reside safely in the community, right? This is around how does
Wow.
someone stay safe in the community with wrap services to keep them there. And then we came up with a list of those services. Yeah.
So before we get into that, I just want to share with my listeners how incredibly awesome this is. And the reason I'm excited about it is because traditionally we have always had this um, kind of blinkers on in our culture, I think, and maybe you would agree with me, JC, around what Medicaid services are. What is the delivery paradigm for people who are getting this assistance? And it's always been very medical. It's
Mhm.
always been very strictly about, you know, doctor visits, hospital visits, medication, and other things specifically sort of with. So the whole idea that we are expanding the definition of how to provide these services to include things that will are not directly medical. That's pretty profound. And is California the only state doing this, JC, or is this happening elsewhere?
No, there are other states doing this. I don't know if there's any states doing it at the level we are. We're offering 14 different what we call community supports.
Wow.
Um, but there are other states that are in this space. We have Oregon and Arizona who are doing really great work in this space, especially around the housing services. But I think California by far really tried to ensure that we had the full continuum of these housing and housing support services. And I mean that in a real way because we really saw it as a gap. Healthcare is built assuming somebody actually has a home to recover in, to to be able to receive services if they get a diagnosis to be in. And we clearly saw an intersection in the population we serve in California that are experiencing homelessness, don't have a home, or their home is not meeting their needs to be able to safely reside and continue to reside in the community, which for us is a goal. We want people to be able to live in the community, live in their home or an assisted living environment that allows them to receive those then medical services that they need as well.
So it seems like common sense to me, but you probably had to prove that it would ultimately be more efficient for the system, that in the way that in the sense that the cost of the Medicaid program in California would be less because of this more holistic approach. Is that right?
We did. So we had to convince the federal government that
Right.
this is both medically appropriate and cost effective. And just because it's a non-traditional, non-medical service doesn't mean it's not medically appropriate. Let me just give you an example that can be
Please.
tangible. So someone experiencing homelessness gets admitted into a hospital, and uh, otherwise they become in a place where the physician wants to discharge them. However, they're probably going to need some home health services. They have wounds or other pieces. They maybe had a procedure that you would otherwise go to your home to recover in, maybe have home health services or something along those lines. Well, in this case, before these services are available, that individual may languish in an inpatient bed for a longer period of time because they don't have somewhere to discharge to. They don't have a safe place to recover, or they get discharged into the streets, and that's not the best place. Here, what we did is provide what we call recuperative care and short-term post-hospitalization housing, where somebody can be discharged from an inpatient bed to medical respite or short-term housing to be able to get the recovery services that they need. And in our ideal world, also connect them with housing transition services so that if they need housing, they can start getting enhanced care management to really tie them into housing services and supports. And ultimately, the goal is to get them housed. But before, they kind of didn't have that full continuum. They didn't have a step down ability other than being discharged to the street, which for many people who have complex medical conditions or disabilities, that's not the best ideal place for them to be discharged to if they're trying to recover from an acute, stay. And so that is kind of what we're trying to do. We're trying to build a true continuum of care and services and supports for someone experiencing homelessness to ultimately be able to heal and improve their health outcomes.
So let's dig in a little bit. What are some of the community supports that are affiliated with this program? And not just with regard to homeless individuals, but with regards to other people on Medi-Cal in California, Medicaid, everywhere else, that
Yes.
that they might be able to take advantage of as recipients of this service.
Sure. So I'll kind of go through each of them, and I'll bundle and show how some of them connect as well. So we have what we call the bundle of housing support services. So we have housing navigation services, we have housing deposits, and then we have housing sustaining services. The reason why we call them the three, because the first one is you identify someone experiencing homelessness, or maybe being released from an incarcerated setting or an institutional setting that would otherwise be released into homelessness. And you can connect them with housing navigation services, getting a housing voucher, getting connected to the continuum of care. And then if they find housing, you can pay for the deposits, first, last month's rent, utility deposits to get them housed. And then you also have sustaining services where once someone's housed, if someone was experiencing homelessness for a very long period of time, they're going to need assistance to remain housed, working with the landlord, teaching them how to pay bills, working with them through those various sustaining services, because once they're housed, we want them to stay housed. So that's what we call the housing bundle, for lack of a better description. But we also know that there are intersections across healthcare where we wanted to have a step down opportunity for someone who otherwise doesn't have a home. And that's what we call recuperative care, or what some people call medical respite. And that can be covered for 90 days. Someone can be discharged from an inpatient stay, like I just mentioned, to a recuperative care bed. And then we have both physical health and behavioral health recuperative care beds. We have combinations of those. And then we have a little bit of a longer benefit, what's called short-term post-hospitalization housing. And that's for up to 6 months, where someone could be discharged to, it's a little bit lower level of care. So you have different levels of care. You could also have someone go to recuperative care and then short-term post-hospitalization housing to get a whole 9 months of those housing services. Both of those are clinically enriched services. So you have clinical help if you need that. Home health that I was mentioning can come on site. You can get your medications. You have someone checking on you. But it also covers meals, room and board, the full 9 yards, right? So those two pieces. We also implemented what we call habilitation services, so day programs where someone can, in the community or in the home, really be getting services around necessary life skills, how to do budgeting, how to cook, how to clean, how to maintain interpersonal relationships so that they can remain housed, how to reintegrate back into the community, and having reimbursement pieces tied to those pieces as well. But then I also want to talk around, some of it is also preventative. So we're also covering things where someone's in a skilled nursing facility. And maybe they've been there for a long time, but they want to transition to the community and they're healthy enough to transition to the community. So we'll pay for transitions from a skilled nursing facility into a home, and make sure that they have the wraparound services that they need to stay safely in that home. Or if they're in their home, but the family's thinking they need some additional services to not go into a skilled nursing facility, so we can prevent that skilled nursing facility stay. But say they don't have a home, maybe they don't have family or circle of support. We will also pay for these transitions to an assisted living environment where they can transition to an assisted living environment and then pay for the wrap medical services that may be needed for that individual in a skilled nursing facility that typically would be covered under kind of traditional in Medicaid 1915C waivers, or what we call home and community based waivers, but this allows it to be outside of those waivers, so available for all individuals that meet that level of care. So those are two pieces that we're really excited about as well. But then also, if someone goes to a home, for example, it would also allow us to do home modifications. So if somebody needs a ramp to be able to stay safely in their home, or a bar in their shower so they don't slip and fall when they're showering, we are also paying for those home modifications so someone can stay safely in
Okay.
their home and not go into an institutional care or
This
have
is
that fall
great.
that goes them back to the hospital, right? Or
So,
to widen their doorways. Those are things, home modifications are another example of things that we're covering here.
wow. So there is an awful lot there, but I do want to be clear. Let's suppose somebody has stable housing, is not coming off the streets, is not coming out of a sniff, but they are on Medi-Cal. Are any of these community supports available to them at all, or do they have to be coming out of a medical or out of a quote unquote medical environment to take advantage of any of the things you just talked about?
So, for example, the environmental accessibility adaptations, or what we call home modifications, anyone on Medicaid, as long as they have a need, a demonstrated need for those pieces, would be eligible for those. They don't have to be coming just out of a skilled nursing facility or inpatient stay, but typically, in order to get something like that covered, they're at that acute level, of service, more at risk of falling or needing a ramp because they need to be able to
Right,
get into their home.
but let's suppose somebody just wants help paying their deposit or first month's rent, and they already have stable housing. Is that an option?
That is not an option. It does
It's
have
not
to,
like everyone on Medi-Cal suddenly can get
right.
housing navigation services. It isn't
Yeah,
like
no,
that.
there is criteria for all of these. For example, that housing bundle, that is for people experiencing homelessness. So they don't have
Right.
a home, and those for recuperative care or short-term post-hospitalization housing. Those ones are people experiencing homelessness. But there are some home modifications, medically supportive foods or medically tailored meals, um, asthma remediation. Those are things that you can just be in the broad Medicaid program. You don't have to be experiencing homelessness, but you do have to meet a certain level of criteria, right, in order to be able to receive those types of supports.
I understand. So it would seem to me, and it sounds really interesting, and I think it's a really smart way to handle some of the challenges of people coming out of homelessness or coming out of SNFs, skilled nursing facilities. Um, but it would seem to me that there may be challenges in terms of the delivery because the agencies and supports that are in place in the medical establishments may not know or want to provide, housing navigation or some of these other things you talked about. So how do you navigate that? How do you find a delivery model that isn't so bureaucratic and tied up with red tape and all these different agencies that it becomes, so difficult for people navigate who may be dealing with mental health challenges as well, or may not have adequate support in their family or in their community.
Yeah. So kind of two things is what I'd say. The first one is this also is coupled with a benefit that we call enhanced care management. So individuals who are often going to be eligible for these types of services are also
Mhm.
eligible for enhanced care management. And that's where we have a dedicated care manager whose responsibility is to help coordinate all of those various pieces for the individual. Because you are right. Oftentimes someone has these needs, it takes a lot of coordination across a number of people. And so they oftentimes will be eligible for and are receiving it at the same time, kind of enhanced care coordination to kind of tie those pieces together. So that's from the member's perspective. But then from the provider perspective, I will be honest with you, we are asking managed care plans who've never paid for housing, supportive services, to pay for something that they know very historically little about. And so that
Yeah,
has been a monumental task for the state of California, where, because the thing is, what I tell the health plans, just like you don't perform surgery,
yeah,
I don't want you to think you're now a housing expert and doing this on your own, right?
right.
They should be contracting with, just like they contract with surgeons to do surgery, community-based organizations who do this all the time. They just haven't been reimbursed by Medicaid to do it before.
I
And
see.
so those partnerships, yeah.
So in California, what are some of the big agencies that are working with the HMOs and the other healthcare organizations
Yeah.
to partner to deliver services under this new program?
So we had been doing pilots in California. So we actually have a large number of our counties who have been providing many of these services. We also have those that are in the housing and homelessness space, community-based organizations who have been doing this for a very long time through our continuums of care and housing continuums. And so bringing those on as contracted providers. We also have a large number of public hospital systems who've really wanted to build out that full continuum of services and often are the ones who provide services to some of our most vulnerable individuals. And so they've done a significant build out as well. So it's really relying on counties, public hospital systems, safety net providers, and then really community-based organizations. And I think that last one is the one where we're doing a lot of work with because they aren't as the first two are used to billing for Medicaid services or Medi-Cal in
Right.
California. The community-based organizations, it's been a larger transition for them because they're not used to authorizations or documentation in that way.
Yeah,
Oftentimes they were funded by grants or other dollars. And so that has been a lot of conversations around that.
I see. So you've been you've been rolling this out over the last year, 18 months, right? This
Correct?
is yeah. And is the rollout of it still in progress or is it
Yes. So we
yeah.
have the enhanced care management, we're rolling it out in 6-month increments. So
Mhm.
populations of focus will come up each 6 months. And then the community supports, we essentially let managed care plans elect to bring up community supports every 6 months as well. And so we have different community supports coming up in different counties each 6-month period. And we anticipate this will take, to be honest with you, a full 3 to 5 years to fully implement. We have certain parts of the state where we don't even have some of these providers today. And so we are actually
Oh,
also providing grants directly from the Department of Healthcare Services to, where there may be a small CBO, but we need them to be able to provide services to more people. So we're providing grants to them so they can scale up, figure out, update their system so that they can bill us or communicate or have data sharing happening. And so we're doing what we call providing access and transforming health. It's called Path Fund grants to help fund providers who are out there that we want them to join the Medi-Cal program, contract with managed care plans, but funding them for that startup so that they can join. So those are also happening. That's how we're going to try to scale up across the entire state.
you mentioned a term that I wasn't familiar with, and my listeners may not be. CBO? What were
Oh,
you referring to?
community-based organization. Thank
Okay,
you.
okay,
Sorry. In
okay.
healthcare, we use a lot of acronyms. So thank
Yeah,
you
we
for
do.
calling me out on that.
We do that in real estate also.
Yeah.
All right. So it all sounds very exciting. What do you think? And have you been involved since the launch of it? Have you
I
been?
have, yes, yes.
Okay. What has been so far the biggest unexpected challenge that you've come up against? The biggest thing that's been, wow, I wasn't expecting that, and this is something we need to work through. And what is that for you?
So we always knew this was I mean, huge undertaking, just to be clear. Um, but and we knew that requiring managed care plans to cover these services was a lot. So we had done massive policy guidance and technical assistance and all these meetings. The thing that is really showing up as one of the biggest implementation barriers so far is the fact that, like I was saying, managed care plans know how to authorize medical services. They know what it takes before you get this surgery or an MRI, but they all kind of approach the authorization criteria or review criteria for these services a little differently, is what I would say. And so, as a provider in a community who has a contract with maybe 3 or 4 managed care plans, and they're all approaching it a little different, that's creating a lot of provider burden, to be honest with you. And so we went on a listening tour this year to kind of say what's working, what's not working. And oh my goodness, we heard this loud and
Mm.
clear. The admin burden of the different authorization forms and processes and data fields. And so we're actually taking that back and we're workshopping on that with providers and plans. How do we streamline some of that? How do we make it more standard for these providers? Because it's pretty predictable in healthcare how to get other things authorized, right? Doctors know how to ask for an MRI or when they should have an MRI versus not, right? So, how do we standardize that a little bit more so that each plan or provider isn't reinventing the wheel across every different county? And so, we are
Right.
doing some great workshops. We're going to be releasing some updated guidance in July of this year and then in December based on those work groups. And that's just, when you're doing something this big and this new, you're kind of creating things at the same time. And so the nice thing is the team recognized that quickly, and now we're working to kind of help streamline some of that as well. So that was the biggest shock. We still have some work to do, is what I would say.
Right, right. So do you have any metrics so far, if you're pushing the needle, and making a difference with this new system, or is it too early?
I think it's still really early, but what I would say is we now have a large number of providers. For example, we increased, I want to say, by over 50% from one quarter to the next of providers that have enrolled and are now providing services, right? So we're really starting to see the number of providers increase, which we have to have providers in order for services to increase. So that's
Right.
a win. So we're really watching that trend. How do we see more and more providers coming on board? And we are seeing that trend happening every single quarter, increase of number of providers enrolling to provide the services. And then we're starting to see the number of services increase as well. But since we have a data lag, you know what I mean? We have 12 months to submit a claim for a service. We think it's a little too early, but we've started posting fact sheets in regards to the trends that we are seeing. We do know, for example, though, that we have the 3 bundle housing in all 58 counties in the entire state of California, which we thought is a remarkable for the first year. We didn't know if we would get the housing suite bundle up that fast in all of our counties. So that's a huge success for us. And ultimately, what we want to do in California is not just have these be under, currently the authority they're under is called in lieu of services. That's way too wonky for people to understand, but we want them to be full blown benefits that we can kind of ensure people can have access to. Right now, we're building that network, which is what we need to do to be able to flip them to a full, meet the demand that's there. We need more providers to kind of meet that demand. So we're working on increasing providers, which ultimately will see those services increase as well.
Are you still confident that ultimately this will lower healthcare costs and help with the homelessness problem in general?
Yeah, I mean, we're one piece of that big puzzle, you know what I mean?
Yeah.
But we've already had, and even just through the third quarter, 23,000 people experiencing homelessness served by community supports. That's pretty good, right?
Yeah.
In the grand scheme of things. And so we do know that it's getting out, and people are getting services. And so, ultimately, though, we just had our the pilots I was telling you about, that independent evaluation by UCLA, someone not the department, came out saying, yes, these types of both the care coordination and community supports, reduce emergency room stays, reduce inpatient stays. Ultimately, the overall cost is still lower for these individuals. So it is showing even in independent evaluations that these types of investments do ultimately have cost savings tied to them. And the bigger thing for us that evaluation showed is it showed that they were connecting to their healthcare services, getting connected into those other
Wow.
medical services they need. One of the biggest things we saw is actually people getting connected in through housing who also had substance use were more compliant with their substance use treatment services and seeing those types of outcomes come out of it as well. So those are great outcomes from our perspective. And so we're really excited about where it's going. A lot of work to be done, but really good outcomes at this point.
Um, if do you have that AUCLA study? Is it a public document that I could share with my listeners and
It
viewers?
is. Yes, our,
Awesome.
our, our Office of Communications can get you a link. It's posted on our website.
Perfect. Perfect. So what lessons are there here, as we wind down with our time for other states, around Medicaid and community, broader community support? What can California share with the nation?
Yeah. I mean, what I would say is I do think Medicaid has a role in regards to funding and providing some of these non-traditional supports. And I do think that there is a clear, and we're not, like you were mentioning earlier, we're not doing this for everybody in our Medicaid program, right? Not everybody's going to get a housing deposit paid for, but there is an intersection where it can be very medically appropriate, cost effective, and help potentially change the trajectory of someone's life. And in my opinion, that is the core of Medicaid. We're either here for a moment in someone's life or their entire life. We serve the full spectrum. And I think doing what we can to ensure that we're providing those services and supports for our members to change the trajectory of their life or to make sure that they can live a healthier, happier life, that's what we're here to do every single day. And so I think it
Wow.
fits right in that world. And so any other Medicaid program who wants the access to all of our research that we did, the literature reviews to demonstrate how effective these things can be, I'm happy to chat with them.
Well, that brings me to my next question, and that is if people in other states who are advocates or who are in the Medicaid world want to learn more about this, how do they do that?
Yeah, so we have a lot of resources on our website if anyone is interested that we can make available. Also, I think a lot of other states are really starting to dig in this space. So they may be surprised that other states, other states will kind of look and watch and listen and learn to how things are going. But I think that they'd be surprised at how much this is happening or starting to happen in other states as well. And so I would say they should definitely be advocating for it because we think that it will be a really important thing for how we all move forward in Medicaid moving forward.
And I will share that website with my show notes when I post
Great.
this episode. Now, let's suppose somebody's listening to this who is on Medi-Cal in California and says, "Oh, I like that home modification thing. I need a ramp." What should they do?
They should really reach out to their managed care plan and see if that's something that they would be eligible for. The managed care plan will have a
Right.
process. Well, they also have to make sure their managed care plan is offering it yet, right? Because we're implementing this over time. So they can reach out, they can talk to their managed care plan, they can see if that's something that they're offering, and they can see if they're eligible.
By definition, everybody on Medi-Cal is on a managed care plan, right?
So in California, we are at about 96% in managed care today. And by January 1 of 2024, 99.3% of our lives will be in managed care. So
I see.
eventually by Jan 1 of 24, majority in California will be on managed care.
Right.
It changes by states just to, yeah.
Wow. This has been really, really helpful, and really interesting. Is there anything that I haven't asked you that it's important that people know about CalAim and what you're doing?
I think the only thing I'd say is one of the things we're really trying to do with CalAim is break down the traditional walls of healthcare and meet people where they are. And we really genuinely mean that, meeting people, whether it's on the street, in a shelter, in a facility that helps them transition smoothly. I mean, that's really what we're trying to achieve here because healthcare is working for a number of people, but it's not working for everyone. And so, how do we think differently about healthcare that gets it to people who really need these services? And that means we have to think differently. And so, I think that's what we're trying to do with CalAim.
Well, I think it's a noble goal. And I know that people tend to be really negative sometimes about bureaucracy and about the role of government. And I'm hopeful that what you're doing will help make lives better for people. And I appreciate you spending time with me and my listeners to talk about it and share your enthusiasm, your clear enthusiasm for it.
Yes.
Thank you so much for being on my show.
Thank you for the invitation.
All
Hey,
right.
hey, JC, just to make sure that was the final evaluation of the California Whole Person Care
That's
report.
correct. Yes.
There it is. Put it in the chat for you.
All right. All right. I'll put both of those in my show notes, and I will email your office and let you know when it's going to come be be downloaded. JC, what is a good mailing address for you? Like direct snail mail?
Let me Kat, do you have our office address offhand?
I think